Good evening, everybody. Good evening, good evening, good evening. Thank you for coming out for another MS Views and News program. This is our 16th program of this year, and we still have 4 remaining. Good thing. We're doing a lot of programs these days, and we're going to continue to do them into 2013. So, first off, I want to thank EMD Serono for giving us their education grant to do this program this evening. We also want to thank our sponsors. We have Accorda, we have Teva, Biogen, Avon, Questcor, and Pfizer. And again, we couldn't do these programs without the sponsorships and the education grants that we get from these various pharmaceutical companies. And we also want to thank all of you for attending our programs, because again, we can't have programs if you're not here. Tonight, we have urologist Dr. Samowitz. Dr. Samowitz, many of you know, many of you don't know, but others do know. He's done programs for us in the past, and he'll be speaking also at our symposium that we'll be doing in November 10th. Emails will be coming out for that in the next couple of days. It's going to be another very large program. Also speaking tonight is neurologist Dr. Jeffrey Horstmeyer. And Dr. Horstmeyer, many people know. Many people from this room visit with him. And Dr. Horstmeyer will also be attending the program in November.
Good evening. First off, I want to thank Stu for his organizing skills, and thank you very much for doing this. I think it's a great thing you do for everybody. As Stu mentioned, I'm a urologist. I do specialize in voiding dysfunction and neurogenic bladder. So I did my fellowship in this area. So I have a fair number of patients that I have to manage with not only multiple sclerosis, but other neurological issues. And I tend to handle the more complicated patients in my group. I'm part of a large group. We have offices in both Aventura and Pembroke Pines. As far as some of the issues that you find with multiple sclerosis related to urology, the most common problem we see is frequency, urinary urgency and frequency, nighttime frequency, which is referred to as nocturia, urinary incontinence, the loss of urine, recurrent urinary tract infection, retention, which is the inability to empty the bladder adequately. And then there's other more significant issues that can occur, things such as even renal failure, problems with catheters, and burning with urination, a neuropathy from voiding, and then sexual dysfunction. The incidence and prevalence that we find with multiple sclerosis and urinary problems, approximately 10% of patients initially present with urinary problems. And out of those, 2%, the voiding issues are their first initial presentation. It's the symptom that brings them to the doctor's office. So there is a significant amount of urinary problems associated with multiple sclerosis. And up to 80% of MS patients are having voiding symptoms at some point. I put this slide in, but then I realized I'm usually talking to a fairly sophisticated audience. I don't need to go through a lot of this. Many of you I know already, and you're quite familiar with the urinary system. But so I'm going to just move forward. Now, the bladder basically is a very simple organ. It basically only has 2 functions. It has to store urine and it has to empty urine. And either one of those functions can be abnormal, but you can also have a combination of the 2. And that's where things get more complicated, particularly in the MS patient. So we're not going to stop there. Voiding dysfunction in multiple sclerosis. So Detrusor Hyperreflexia is a fancy name for overactive bladder. Many of you are familiar with the term overactive bladder because the pharmaceutical companies have advertised it so heavily. There's medications on the market such as Vesicare that uses the television ad with the pipe people. Detrol was around for a long time. Gotta go, gotta go, gotta go. These are well known to the general public. But when you have a neurological diagnosis associated with overactive bladder, it's no longer called OAB. It's no longer overactive bladder. It's then called Detrusor Hyperreflexia. And with MS patients, we have a neurologic explanation for it, It's no longer idiopathic, meaning that it's unexplained, so we refer to it as Detrusor Hyperreflexia, or DH. Bladder areflexia is sort of the opposite. It's where the bladder does not squeeze. The bladder is a muscle, and it's responsible for pushing the urine out when it's time to void. So if the bladder loses its tone, it becomes areflexive, meaning it has no push, or hyporeflexive, that has a weak push, and that can lead to urinary retention. Detrusor sphincter dysynergia is where, well, basically, when the bladder has to store urine, the bladder relaxes and the sphincter and the pelvic floor tighten to hold the urine in. Then when it's time to empty, the bladder contracts and the sphincter and the pelvic floor relax to let the urine out. When the bladder and the sphincter don't talk to each other, when they're not communicating and coordinating properly, you have a bladder that's squeezing against a closed outlet, and it tries to push the urine out and it can't, and it causes significant problems. And this is where I was referring to. You can get a combination of both and difficulties in managing these patients, because Detrusor sphincter dysynergia is not that uncommon in MS patients. You could have decreased bladder compliance. Well, the bladder is a muscle, and therefore it has to be able to expand to store, and it has to contract to empty. But if the bladder wall itself becomes less elastic, if it becomes stiff, partially from fibrosis, which is a type of scarring, and the bladder loses its compliance, it's no longer a flexible muscle, it's a low compliance or poor compliance bladder, and those are difficult to manage. High post-void residuals are associated with urinary tract infections and bladder stones. If the bladder is not emptying completely and urine gets left behind, this stagnant urine can become infected, and that's a urinary tract infection. And if that crystallizes, or a crystal forms and grows in the bladder, you could develop bladder stones. And I found very significant bladder stones in patients with MS and neurogenic bladder. And then the bladder stone and the infection are interrelated, because once a stone becomes infected, it causes more infections, and infection causes more stone, and it's a vicious cycle. So you can't get rid of the infection until you get rid of the stone. And since when you take an antibiotic, it doesn't penetrate the stone. It may clean off the surface, but it doesn't penetrate the stone. You get rid of the infection temporarily with the antibiotics, but then the infection comes back again as the bacteria grow out of the core of the stone. And then high intravesicular pressures and upper tract deterioration. When over time the pressures are transmitted from the bladder, if you have a high pressure system, if the patient is having dysynergia and they're using very high pressures to void, some of that pressure will be transmitted back up to the kidneys. And if this is done over long periods of time, eventually the kidneys will be damaged by the high pressure. And eventually this can lead to renal failure. And this is no longer as common as it once was, but there was a time where renal failure was a very prevalent problem with multiple sclerosis patients because of neurogenic bladder and high pressure voiding. So Detrusor hyperreflexia is the most common finding that we have in patients, and it occurs in up to about 90% of the patients that are having voiding symptoms. And of the patients with hyperreflexia, about a third of those have the dysynergia that we talked about a few minutes earlier. Bladder areflexia, or the weak bladder, the flaccid bladder, it can occur in about 20%, and some of that progress on to hyperreflexia. So the one thing I'm sure you're all very familiar with is that nothing is stable, nothing is constant with MS, and things change all the time. And one patient is different from another, and the same patient can be different from time to time. This is a study that we do to try to understand the bladder. It's called urodynamics. And each of these channels here, there's usually 6 channels. So there's 1, 2, 3, 4, 5, 6, 7. This one has 7. But each of these channels is measuring different things in the office while we have you hooked up to a computer. We're measuring how your bladder handles the fluid challenge while we're at the same time doing an EMG of the pelvic floor. And at some point, we will try to have you urinate while you're hooked up to the computer to see if you're able to void well. So you can't really read the parameters here, but some of these are for pressure of the bladder, some of these are pressure of the abdomen, and then the computer subtracts one from the other, and that figures out what the real bladder pressure is. And then you have the flow, this is the electrical, the EMG of the pelvic floor, and so on, and this is the bladder filling. So bottom line is this gives us a lot of useful information about the bladder, and it's done in the office. It takes about a half hour, 45 minutes. It's cold, it's wet, it's uncomfortable, it's awkward having to try to urinate while you're hooked up to a machine, but it does give us a lot of useful information in understanding where you are in terms of bladder function. So in terms of management, well, you know, we have to set our goals with the neurogenic bladder patient. And the first one is we want to be able to help them to empty their bladder adequately at low pressure. We don't want them voiding at high pressures because that, again, can transmit pressure back up to the kidney and cause kidney damage. And we have to have reasonably good emptying. We want them to be able to stay dry. Continence is obviously very, very important, and social continence is a critical factor. We want to preserve the upper tracts, as we mentioned, and years ago, 55% of MS patients could have complications leading to mortality, so from urinary problems. So that number is much less nowadays, obviously. And then being able to give the patient adequate control. In other words, that they don't have to live their lives around their bladder, that the bladder is not controlling their lives, and that they have able to go out and do things and have a good quality of life. When a patient has Detrusor Hyperreflexia, that urinary frequency and urgency problem, one of the first things that we'll give the patient is a anti-cholinergic or anti-muscarinic medicine. Again, those are the ones that many of you are already probably familiar: Vesicare, oxybutynin, Detrol, Enablex, Sanctura. Excuse me. There's quite a number of them out there. There's a little bit of variation amongst these. Some of them have more side effects than others. Some of them have more dry mouth associated with them than others. But for the most part, they're very, very similar. Dry mouth and constipation are the major side effects. There's about 7 pills out there, and then about 2 or 3 years ago, they came out with a gel called Gelneek. And Gelneek is the oxybutynin gel that can be used. It's not very strong, but at least it has minimal side effects. Interstim is a device that got FDA approval in 1997. And what it is basically is a pacemaker that stimulates the nerves that go to the bladder. It's not technically a pacemaker for the bladder, but what it does is it helps the bladder to function more normally by stimulating the nerves that go to the bladder. And it is for this reason why it has somewhat mixed results with the MS patient. The Interstim is done in 2 phases. The first phase we do in our office under local anesthesia, and we pass these little wires in through the lower back, through the sacrum. And these right and left wires placed under local anesthesia. We then send the patient home with these little wires taped on their back. They get something that looks a little bit like a pager or a cell phone, and the wire plugs into that. They have to wear this for a week. And during that week, the patient will record how they do in terms of their urinary symptoms. If they come back and they have at least a 50% improvement in their urinary symptoms, it means they're a candidate for the permanent placement of Interstim. And the permanent placement of Interstim is done as an outpatient, again, mostly under local with some sedation. It's done as an outpatient in an operating room. And we place this stopwatch-sized device in the upper buttock, in the fat, and then we put the wires back in again. And the battery's good for about 7 years, and the patient goes home with sort of a remote control that works like a garage door opener or a remote control for a television, and they can adjust their Interstim as they see fit. And this has about a 70% improvement rate for patients. It works better for the patients that have Detrusor Hyperreflexia than it does for the patients that have the areflexive bladder, the weak bladder, the ones with retention. But it does interestingly work at both ends of the spectrum, which is why we don't exactly know why it works. But it does work. The problem with the MS patient, however, is that this requires stimulation of the nerves that go to the bladder. And because the demyelination affects those nerves may not work so well, so that the interstim doesn't seem to have the same length of time of effectiveness as it does in other patients with neurogenic bladder. But I have a number of MS patients that I put interstim in, and they've gotten at least several years of good quality response. Another treatment that we sometimes use for patients that have severe Detrusor Hyperreflexia is Botox. I was involved in the clinical research studies with Botox, and I've had a lot of experience with it, and it's an amazing drug. It involves injections directly into the bladder with a cystoscope. We have to go in the bladder, and we give the patient about 20 to 30 little injections scattered throughout the bladder of Botox. And what we're doing is we're partially paralyzing the bladder. Botox typically lasts somewhere between 6 to 9 months in these patients, and during that time, the bladder may, we see improvement in most patients that have Detrusor Hyperreflexia. There's a small risk that some of these patients will go into retention, but it's a small risk. There are those patients too that have indwelling catheters who still leak. Their bladders are so overactive, so hyperreflexive that even though there's a catheter in draining their urine, they'll leak around the catheter, they'll still have problems with spasm. And for these patients, we also will use Botox. It's nice because the patient no longer has to take another medication. It's injected, and there's no longer an oral medication for those patients. Pelvic floor muscle rehabilitation. This is physical therapy that will sometimes help patients. It's not easy to do. Even patients that don't have muscle weakness have a difficult time with some of these exercises. They're non-intuitive exercises. They're similar to the Kegel exercises that you probably are familiar with. They're helpful, but they're not easy. But I used to have a physical therapist that worked with my practice. She was very good. Unfortunately, just recently, she resigned where she worked as a physical therapist, and we're trying now to recruit her to come work in our office. So right now that's a work in progress, but there aren't many physical therapists that are really specialized in pelvic rehabilitation. And if you find one, you're very lucky, and you should stick with them because they can be extremely helpful if they know what they're doing. In rare cases, we have patients that only have urinary frequency at night, nocturia. And there is a pill that we often will use in children called DDAVP. It's actually a hormone, desmopressin, that inhibits the production of urine temporarily. And it can be used for a patient that is only having problems at night. We have to be somewhat careful because during that time, the patient is not making urine. They can develop hyponatremia or low sodium in their blood. But that's a rare issue. As long as patients are monitored, it does work. But it's really kind of doing an end round the problem with the bladder by just limiting the urine production. It's not really working on the bladder directly. It's not solving the problem. With the male, we could sometimes take advantage of being able to use an external condom. The patient can wear an external device, sometimes known as a Texas catheter or condom catheter, and this will collect urine, but they're still incontinent, but at least they're not having to wear a pad or a diaper and have problems with skin breakdown or be concerned about odor or such other issues. So I have a number of MS patients that, if they're in a wheelchair especially, this is not a bad solution for them. And when patients have intractable overactive bladder, Detrusor Hyperreflexia, and dyssynergia, we sometimes will have to make them incontinent because their sphincters aren't relaxing when they need to. So we sometimes have to do a little procedure with our scope through the urinary tract and cut through the sphincter so that they can wear a condom catheter instead of going into retention and not being able to empty their bladder. So Detrusor Areflexia is those weak bladders that aren't able to empty out. The urine gets left behind. The patient's in retention. The first medication that we can use for this are alpha blockers. These were originally developed to be blood pressure medicines, and then over time, they found that men with these medicines for their blood pressure were urinating better because it relaxed the bladder outlet. And the medications were made more specific. We're now using alpha-1A alpha blockers, which means that they're very, very selective for the receptors in the urinary tract, and they no longer affect blood pressure, which is very nice for a lot of patients because if they have normal blood pressure, this medicine does not lower their blood pressure. And it relaxes the bladder outlet. It's mostly used in men with enlarged prostates, but we use it a lot in MS patients because so many of them do have some dyssynergia that by relaxing that muscle, the outlet, they can empty out more effectively. And the nice thing is it, again, has very little in the way of side effects. The medications that you're probably familiar with are Flomax, which is now generic, as well as Rapaflo and Uroxetrol. And you can go up to even 2 of those a day if necessary. Intermittent catheterization, I'm going to probably talk a little bit about that more, but that's where the patient learns to be able to empty their bladder on their own by inserting a catheter, draining their bladder, and then sometimes reusing the catheter, but doing this periodically and emptying the bladder on their own with a catheter, not leaving it in, but temporarily. Again, I mentioned earlier that InterStim does work somewhat for these patients that have a hypocontractile bladder, Areflexia bladder, but it doesn't work as well in this group as it does in the group that has the Detrusor Hyperreflexia, the overactive bladder. And then there's indwelling catheters. Now, we could put a catheter in through the urethra in the female, that's in the vagina, and the male in the penis. Or if necessary, it's sometimes more comfortable for the patient and easier to manage if we put the catheter directly into the bladder through the skin, below the belly button. And those tubes have to be changed once a month. It does work. If a patient gets a suprapubic tube, it doesn't burn any bridges. If the patient later on decides they don't want the tube, we take it out, and in a matter of hours, that hole closes up. But they do have to be seen once a month to change the catheter. And then, of course, to make things more complicated, once men reach middle age, they start having enlargement of their prostate. So not only are we having to worry about their bladder, their neurogenic bladder, and their neurogenic sphincter, to make things more complicated, we also throw in obstruction with the prostate. So that makes the whole equation more complicated. This slide was just meant to give some information on self-intermittent catheterization, where the patient simply slides this catheter up through the urinary tract into the bladder and drains the bladder and then takes the catheter out. Some of these catheters have a fixed bag already to them. Some of the patients just empty this right directly into the toilet. And once you get the hang of this, this is actually much easier than it looks and becomes like brushing your teeth. For the females, they have a very tiny little catheter that's the size of a lipstick case, and it's very discreet so that the female patient can carry this with her and go into the stall, catheterize herself, and then it's very discreet. They don't have to carry a lot of supplies with them. So the process of clean intermittent catheterization, now this is clean. You don't have to be sterile to do this. Patients remarkably really can avoid infections. And what it's involved with, you wash your hands and the genitalia with soap and water. And if you don't have soap and water available, you can carry these little prepackaged towelettes. The catheter is placed in the bladder, drained, and then it's either in the toilet. In some cases, these catheters have attached to them a bag already so that if there's not a bathroom nearby or a place to drain the urine, it goes directly into the bag and the bag seals up so that it stays sterile and it can be disposed of easily. The catheter is removed, and you can either use a new catheter for each self-catheterization, or you can reuse these catheters. These catheters can be soaked After you take the catheter home, you soak it in isopropyl alcohol, rubbing alcohol for a few hours, and shake it dry, air dry, and then put it in a clean Ziploc baggie, and it's pretty much like new. Well, there are still some patients that will get recurrent urinary tract infection, and there's a way of sometimes helping these patients to avoid significant infections. Obviously, we have a number of antibiotics, but in patients that are getting recurrent infection, if you keep using antibiotics, eventually they get resistance. So sometimes we have to use a medication called methenamine. Methenamine is an old-time medicine that has been around since before we invented antibiotics. And it's an antiseptic. It's not technically an antibiotic, but it's antiseptic. And this will lower the bacteria count to the point where the patient doesn't feel it. It's not giving them any problems. And this methenamine has to be taken a couple times a day. It works best in an acid environment. For that matter, bacteria don't like an acid environment. So what I have my patients do is take extra vitamin C a few times a day, like 1,000 milligrams of vitamin C twice a day. And they'll use the cheap vitamin C. You don't want one that's designed to stay in the body. Vitamin C is a water-soluble vitamin, and therefore it passes through the body, ends up in the urine very quickly. And it's ascorbic acid, and ascorbic acid makes the urine acidic, and therefore the bacteria don't grow as well. Cranberry capsules will help also avoid infection. Cranberry blocks the adhesion of the bacteria to the wall. Cranberry juice would work, except I don't know if you've ever tried to juice a cranberry. There's not a lot of juice in a cranberry. Cranberry juice is mostly sugar water, so you're actually better off with cranberry capsules, or basically simply cranberries that have been freeze-dried, crushed into a powder, and put in capsules. And it doesn't have to be any more fancy than that. And there's other ways that we can help patients to avoid infection as well. Some patients have dysuria. That means burning in the urinary tract, especially with voiding. With the MS patients, this is sometimes related to a neuropathic reason. There's an unclear etiology, an unclear explanation why they have this burning. And so there's certain medications out there that will numb the urinary tract. They typically are dyes. They either turn the urine a bright orange, like a neon orange, and they stain, or there's one that's called Urabel or Hyophin, and that turns it greenish blue, and that has methylene blue in it, and that also numbs the urinary tract. Other issues that we sometimes have to deal with MS patients is infertility. I do a lot of infertility, and so I see both MS patients and non-MS patients for this, and there are special considerations with the MS patient. They may have difficulties with ejaculation, they may have difficulties with their sperm production, and so we treat those patients accordingly. From having a chronic indwelling catheter, you can eventually get erosion. So sometimes these catheters, when they're left in and not attended to, they will eventually wear through the urethra. We see this sometimes in the female patients. I've had a number of them where they've managed themselves over many years with an indwelling Foley, and eventually the opening to their bladder becomes, so big that they can't stay dry. The catheter can't be made big enough to block up the urine to drain through the catheter. And what we have to do sometimes is close that urethra opening, and then they have to use a suprapubic tube in order to drain their bladder. There's no more opening from through the vagina. And this can happen also to some degree in men as well. Going back to how patients get managed, the one thing with the MS group is that you have to be willing to modify and adjust to their needs. There's no two patients that are alike. Their needs are going to change, and it depends on what's going on. I'm not going to mention any names, but there's one patient that likes to travel a lot, and for her, she'll use an indwelling catheter when she travels. And as a result of this, she's able to go about and have a good quality of life of traveling without having to worry about her bladder. And when she comes back from her trip, we get rid of the indwelling Foley catheter, and this works well for her, and there's no reason why this can't be done intermittently. And we do this sometimes even in patients that don't have MS, where it's a combination of treatments for the patient, and it's whatever works. But in terms of what one center did, this is for particularly patients that had urge incontinence, urinary leak from frequency and urgency but did not have a significant amount of retention. They were emptying their bladder. For them, 10 of them were using just basically the medications. 10 centers were reporting that this was the main treatment. 7 centers were doing intermittent catheterization. 5 were using the alpha blocking agents such as Flomax, and they were using, I guess, baclofen, and then pelvic floor exercises at 4 others. When the patients have incontinence, but they have a large residual that they're retaining, again, intermittent catheterization alone was from 5. And just you can notice there's all different combinations of what to do with these patients. And I'm just trying to point out there's no set formula. And you just have to figure out what is best for that individual patient at the time. I thought you saw that already, okay. In terms of sexual dysfunction, well, in the MS patients, they're a little more complicated than other patients. There's all kinds of things that we have to worry about related to their MS, in addition to common problems that we see with sexual dysfunction. And I'm not going to get into this. This is a whole other topic. But I think it's important to recognize that we're here to help you, and there are options. When it comes to treating men and women, they're very different. Men are pretty simple. We help them to have an erection. Women are much more complicated with sexual dysfunction. We don't understand this. We don't get it. We don't, much too complicated. But female sexual dysfunction disorders, we try to break them down into 3 categories. And the MS patients, as well as other female patients, all will have, issues with these. It's a common problem, and again, we just don't understand it completely, but we're working on it. We're trying. Thank you very much.